A patient walks in with persistent cough lasting 3 weeks or more, often producing sputum or blood. Other primary symptoms include chest pain, unexplained weight loss, night sweats, fever, fatigue, and loss of appetite. Clinical signs include fever, increased respiratory rate, crackles on listening to the chest, and potential oxygen saturation below 90%. The CT shows fibronodular infiltrates. You think it's TB, but what if you are wrong? Fibronodular lung patterns are one of the most misleading findings in radiology. Today, we'll break down the key differential diagnoses and how to never miss the correct one. The classic diagnosis of TB. Tuberculosis is the most common cause, especially in endemic regions. Imaging clues: upper lobe fibrosis, cavitation, tree in bed nodules. Clinical tip: if you see cavitation plus fibronodular pattern, always think TB first. The mimics, where most mistakes happen. 1. Sarcoidosis, bilateral upper lobe fibrosis, perilymphatic nodules, hilar lymphadenopathy. Key differentiator: symmetry plus lymph nodes is equal to think sarcoidosis. 2. Pneumoconiosis, silicosis cold worker, upper lobe nodules, eggshell calcified lymph nodes. Clue: occupational history changes everything. 3. Post-infectious fibrosis, old healed infections, no active nodules. Clue: stable over time is equal to not active disease. 4. Fungal infections, can mimic TB, may show nodules plus cavitation. Clue: immunocompromised patient, think fungal. How to differentiate? Simple approach. Whenever you see fibronodular infiltrates, ask 4 questions. Is it symmetrical or asymmetrical? Are there lymph nodes? Is there cavitation? What is the clinical background? Radiology plus clinical context is equal to correct diagnosis. Look to this smart art for differential diagnosis of fibronodular infiltration. If it is associated with cavitation, always think TB first. But if it is associated with bilateral symmetrical lymphadenopathy in the chest, think sarcoidosis. If there is history of occupational disease such as silicosis or cold workers, your diagnosis is pneumoconiosis. Finally, if fibronodular infiltration is stable over time, think post-infectious fibrosis, but if it is in immunocompromised patient, think fungal infection. Next time you see fibronodular lungs, don't jump to TB immediately. Pause, then analyze and think differential. If this helped you, don't forget to like, subscribe, and check my other radiology differential diagnosis videos.